So hello everyone and welcome to this afternoon's session. We're going to be discussing a new development in a new technology in the cath lab. So standard of care, is it time to really push the envelope and look at the bioadapter technology and really progressing from simple to complex. So very quickly, my name is Mirvat Al-Asnaj. I'm a practicing interventional cardiologist in Saudi Arabia, and with me is a fantastic faculty, David Erling, Nikos Werner, Omar Goktekin, Michael Harnick, and Anthony Wong, very diverse and international faculty here today. So I'm very briefly going to introduce this session to you, but then we're going to go over the evidence. And the primary session is going to focus on the Bioadapter RCT, the 3-year results, and the INFINITY-SWEDEHEART. After that, we're going to look at some practical cases, real-world experience. We're going to look at complex cases, high-risk CHIP-PCI, and we're going to also look at CTO lesions. And Michael is going to take over some of the discussion there. So what we do want to, the objective of today is to really review the unmet clinical needs in PCI and, as I said, the clinical evidence behind it. We want to discuss the potential benefits of a bioadapter technology and really look at examples from our daily practice. Why do we even need to look beyond drug-eluting stents? I think this is something we should all question ourselves. Well, the answer is fairly simple. We've all seen that even as we progress from first generation to second generation drug-eluting stents, and even as we're getting thinner struts, we've really reached a level beyond which we're unable to reduce major adverse cardiovascular events. And we do see that we have an accrued increase in event rates and lumen loss beyond 1 year with drug-eluting stents, no matter what we've done. So we've looked at more intense platelet therapy, more potent antiplatelets. We've looked at drug-eluting stent technologies, but maybe it's time to look beyond that and see what we can do differently. And what we do know is, all of us, we've seen it, particularly with long stents and so on, is that you really do lose that flexibility that you see normally in a normal vessel, a normal healthy vessel, the motility of that vessel. So certainly there's definite dysfunction. The vascular function is lost when we implant metallic stents and we leave it at that. And that's where the bioadapter technology really came in. It's still a metallic stent, but what we do know is that at 6 months, it starts to unlock and starts to uncage. And with that, you get better function and restoration of function. So as you can see, it's still locked from 0 to 6 months. At 6 months, you start to see this unlocking mechanism happen. You start to see restoration of flow. And really the vascular dynamic, I mean, the vessel is dynamic, right? It's not one structure that you measure during systole and diastole. We've all seen it with intracoronary imaging. And what we do see is this, the dynamic changes, and a lot of some of the cases I assume that's going to be presented today is going to show you that pulsatility that we want. And perhaps that is the reason that actually from the data that's going to be presented momentarily, we're going to see an actual reduction in event rates that extends well beyond 6 months and well beyond 1 year. And some data was presented earlier today at EuroPCR. So what I'm going to do is hand over to Nikos and David for their presentations.
Thank you very much. Ladies and gentlemen, it's an honor to present the 3-year data for the Bioadapter randomized controlled trial on behalf of the study committee. And these are my conflicts of interest. And as you know, there has been a lot of publication out there already concerning the Bioadapter stent. We have quite a number of cohort studies and case reports, but we have two major randomized controlled trials, which one is the Bioadapter RCT, including 445 patients, comparing it to the Resolute Onyx stent. And we have the INFINITY-SWEDEHEART study with 2,400 patients, also a one-to-one comparison with the Onyx DES. Both data, the 2-year follow-up for the Bioadapter RCT has been published this year in JACC Intervention, and also the 1-year follow-up has been published last year in The Lancet. So this is a very impressive study program, and it's an honor for me now to present the 3-year data. Just to bring it back into your mind, we have a study, the Bioadapter RCT, with 445 patients in 34 centers, Half of them were enrolled in Germany, Belgium, and New Zealand, and the other half was enrolled in Japan. As mentioned, they were randomized 1-to-1 to the Dynamics Bioadaptor versus the Resolute Onyx DES. We had an imaging subgroup at baseline and 12 months. These were 100 patients. And the 1-year primary endpoint in the intention to treat analysis was target lesion failure. It was a non-inferiority endpoint, and the clinical follow-up is up to 5 years. And I will show you in a second the 3-year clinical follow-up. We saw already after 1 and 2 years a very favorable result in terms of target lesion failure in favor of the Dynamics Bioadaptor study. So here are the baseline characteristics. Patients were quite young, around 67 years old. And the majority of patients were men, as we see that quite often in these studies. Severe cardiovascular risk profile of these patients with hypertension, dyslipidemia, and roughly 30% of diabetic patients. As you can see, we had like 65% with stable coronary artery disease and ACS in around 35%. The most often treated target lesion vessel was the LAD with 50%, as you can see. But there were also other lesions treated, like osteal lesions, bifurcation lesions, moderate to severe calcified plaques. And you can see that all here. So very interesting population, high-risk population with a lot of risk factors and also complex coronary lesions. So this is the reduction in target lesion failure with Bioadaptor at 3-year follow-up compared to DES. This has been shown this morning in a late-breaking session. What we see, and this is very surprising or very impressive, I would need to say, 2.7% of the patients in the Dynamics group had target lesion failure versus 7.3% in the Resolute Onyx group. This was a P of 0.030 for superiority, and please remember that the study was designed for non-inferiority. What we see is a superiority in the primary endpoint target lesion failure. What about the other endpoints? As you can see, cardiovascular death was significantly less often in the Dynamics group compared to Resolute Onyx. Target vessel myocardial infarction was numerically lower in the Dynamics group. However, not significant. There was no significant difference. And clinically driven target lesion revascularization was the same, numerically lower for the Dynamics stent compared to the Resolute Onyx. When we look at comparison 1 year and 3 year, and Mirad already has shown the different course of DES, and what we see here is the same what we see with all drug-eluting stents. We have an increase over time in terms of target lesion failure. When you look at the gray bars for the Resolute Onyx stent, 2.7 to 7.2 at 3-year follow-up, while with the Dynamics we have a very much slower increase in target lesion failure with 1.4% to 2.7% at 3-year. Again, this was a significant different between groups. And the same holds true for the really hard endpoint, cardiovascular death. Again, when you look at the Dynamics, the blue bars, there was virtually no increase in cardiovascular death over 3 years, and we see different observations when looking at the drug-eluting stent. Same holds true for target vessel myocardial infarction and also for the clinically driven target lesion revascularization. So here's the Kaplan-Meier curve to see the benefit with the Bioadaptor from 6 months to 3 years. And you see that there's more or less a plateau for the Bioadaptor over years, while there's an increase in target lesion failure numbers, as shown with the previous bars, for the drug-eluting stent. And this was significantly different at 36 months. So what about the subgroups? One important subgroup are the patients who are treated within the LAD. Remember, about 50% of the study population was treated in the LAD. The LAD is the most important vessel in most of our patients. And when you look at this subgroup of LAD lesion at 3 years, you see the same trend, significant difference in target lesion failure in the LAD, 2.7% over 3 years in the bioadapter group, 10.6% in the DES group, which was significant different. And also when you look at the proximal LAD, so maybe even more important than the total LAD, the proximal LAD shows, again, the numbers are of course lower. Again, it's significant difference between DES and bioadapter, 2.8% for the bioadapter target lesion failure versus 16.7% in the DES group. So I think we have very, very impressive 3-year clinical follow-up. I think this is something really new, what we see here. We have sustained and significantly lower target lesion failure rates with the bioadapter stent compared to DES. We have significant lower rate of cardiac death or heart endpoints. We can reduce heart endpoints by using the bioadapter compared to the DES, and lower rate of clinically relevant and driven revascularizations. We have a substantial clinical benefit with bioadapter and LAD lesions, and especially also in the proximal LAD lesions. And what we see is that we can confirm the durability of treatment benefit from 6 months until the follow-up of 3 years. And we are, of course, very happy to see in another 2 years the 5-year results. Thank you very much.
So we're exactly on time. We're going to go ahead and look at the INFINITY-SWEDEHEART trial, 1-year outcomes. David, over to you.
So thank you. It's a pleasure to be here and report the results from the INFINITY-SWEDEHEART trial. So we have seen this recently, but just to remind you again, the first 6 months, the bioadapter behaves exactly like the best modern drug-eluting stents we have on the market. Thin struts, easy to place, easy to get there, and it gets a high acute gain of lumen. But after 6 months, it opens up, and suddenly you got this dynamic movement in the vessel. So you can have the positive remodeling, the Glogov effect, and you can have pulsatility and hemodynamic modulation. So this is important for the design of this trial, because this should be a large trial, 2,400 patients. It should be large enough to show superiority in really hard endpoints. But the first endpoint was non-inferiority at 1 year, and we fulfilled that with a very high p-value. But the more interesting endpoints are the powered secondary endpoints, which are landmark analysis, because we knew that the first 6 months would be no difference. But what happens when physiology is restored? So those are the most important endpoints from this study. It was conducted in Sweden in 20 sites, using the Swedish registers, the SWEDEHEART and the SCAR, to get background demographics and also ensure complete follow-up of all patients. But we also had blinding of patients, blinding of a CEC committee, we had study oversights, DMC, we had a core lab in Paris and so on. So it's a very thoroughly done study, even if we used our registers to simplify the study. And the first result is after 12 months. The population had relatively complex lesion. 40% had B2 or C lesions. As usual, LAD was the most common vessel. We had a lot of ACS patients. We don't have that in this slide, but there was, I think, around 70% ACS in the trial. And it was tight stenosis, 87% diameter stenosis, and good post-procedure results, around 1% remaining stenosis, according to the operators. So here are the important results. The TLF at 6 months to 12 months. And here you can see a flattening of the curve of the bioadapter, only 2 events out of nearly 1,200 patients, while the Onyx continue to accrue events, as we have seen for all the drug-eluting stents that have been studied on the last 15, 20 years. And a strong p-value for superiority in this landmark analysis. TVF, similar trend, with a strong p-value for benefit for the bioadapter. And here we have the ACS population. As I mentioned, there were a lot of them, more than 900 in each group. And here you see the first 6 months, nothing special happens. They are behaving exactly the same way, the bioadapter and the stent. But beyond 6 months, you see a separation of the curve and only 1 event in these ACS 900 patients in the bioadapter group, and a strong p-value for significance and superiority. The LAD is an important vessel, as we all know, and here you can see a very clear effect with a 73% reduction in event rate in the landmark analysis from 6 to 12 months. And again, the same as we heard before from the bioadapter study, the proximal LAD lesions, nothing happened in the more than 300 lesions that we had bioadapter in, while you had events in the Onyx part. And this is extremely important. We all know the proximal LAD is the widowmaker and so on, but when I talk to people about the bioadapter, what's the first group of patients you want to treat with this? Everyone says LAD, proximal, maybe mid, in relatively young patients that will have this bioadapter for a long time. So this is very convincing results for treating, especially the LAD, where the restenosis rates are higher than other vessels. And in this slide, you see 3 different types of vessels that have a higher risk of restenosis than others, and TLF. And that's the LAD again, that's the small vessels, and that's the long lesions. So these are especially good for the bioadapter to avoid restenosis and TLF. The classical subgroups, old, young, female, male, diabetes, yes, no, STEMI, non-STEMI, LAD, small vessels, and so on, you saw that, bifurcations, complex lesions, they all trend to the same way. There is no p-value for interaction in any of these subgroups. So it seems like the bioadapter is good for any lesion, except instant restenosis, of course, because then you have another stent that cages the vessel. So in summary, INFINITY-SWEDEHEART, large superiority trial, low and non-inferior TLF rates at 12 months, a significant reduction in the landmark analysis for TLF, TVF, and substantial clinical benefit in high-risk subgroups, including ACS, LAD, long lesions, small vessels. So it seems like the bioadapter may represent a long-awaited solution to flatten the event curves following PCI. And we plan to present the 2-year data at TCT later this year. Thank you.
So if you have any questions, please just let us know. There are a few mics in the back, and we're happy to address them. So, I'm going to turn to both of you, Nikos and David, and ask you a few questions about the trials that you showed us today. We do see that after 6 months, a reduction in event rates. And it's not coincidental. That is when we see the uncaging happen. Can you expand a little bit on that?
The mechanism? I don't think we know everything about the mechanism. Generally, I've been doing research in physiology for my whole active clinical doctor's life. So I think physiology is something very, very good. To have pulsatility, to have an endothelium that is stimulated, I think that's very, very important. And then another aspect that we have seen in the sub-studies of the bioadapter trial is that pulsatility seems to reduce the plaque volume. And we have never seen that before. So maybe the squeezing of the vessel makes the plaque be reduced, especially if combined with high-potency statins.
Yeah, and probably there's also some positive remodeling in terms of vessel function and plaque, which may account for the effects, but it's definitely at the moment difficult to explain the whole pathophysiology behind that. But I think, interestingly enough, when you look at both clinical studies, we see exactly the same in both randomized trials, completely independent from each other. There are these mentioned biological explanations for that, and I think this is something we really need to dive a little bit deeper into it to better understand the biological behind that, but that's at least the observation we have.
So given these mechanistic differences, do you foresee a difference in our antithrombotic regimen for patients who are receiving these? Or is there something in the pipeline you want to tell us about?
That's an excellent question, of course. I think we are too early to answer that in detail. But of course, it's interesting to think about these concepts that we, for short, maybe dual antiplatelet therapy and all this stuff, because we see this positive effect after 6 months. At the moment, I think we need to stick to the standards and try to understand it a little bit better now.
So you mentioned subgroup analyses. I know the LAD is probably one of the most important vessels that we address percutaneously, but can you tell us if the results have been consistent across all sub-analyses and expand a little bit on that?
Yeah, I think as you saw, there were no p-value for interaction on any of the different patient characteristics that we usually put in those subgroup analyses. And no, it looks really good, and it seems like the more high-risk lesion, the better effect of the bioadapter.
And perhaps
the LAD data looks like surgical data for the lemur.
It is impressive. I do want to circle back, though, to some of the drug-eluting stent data that we have. And I think both of these trials are perhaps showing very consistent results to drug-eluting stents that we currently have, the platforms that are currently available. Maybe if you can tell us a little bit about those endpoints that we're seeing.
Well, I mean, we have very good drug-eluting stents as they are. But the problem is that when we put in that drug-eluting stent, the problems will continue year after year after year after year. So maybe the one-year results, the event rate is relatively low, but to realize that in this patient, you give him a lifelong trouble. And that's the beauty of the bioadapter, that maybe that is flattened out and you don't have that problem with the treatment. And then we have the DCBs that are a little bit hyped nowadays. And it seems like you need this support. You cannot take away the support totally. You have a very big plaque there, you have calcification. It seems like you need some sort of this dynamic support because the results looks better than for the DCB trials, even they have not been compared directly.
Yeah, that's a fair point. I think it's time to look into the cases. So Michael, maybe I'll hand over to you.
I can mention you can write questions in your phones and send it up here if you want to.
So just to start the discussion, because you will see excellent cases, and I think that it is really important that also we can see the cases in which bioadapters behave as a regular, very good stent, and it will be shown in a minute. Just before we are going to the cases, I think that just a few information regarding the technical issues. So the first thing is that the implantation technique is absolutely the same as the conventional PCI workflow with standard DES. And what is very important also, we can overexpand the stent by 0.5 millimeters over the nominal diameter. Of course, it is typical for our stent. I think that we have to remember that the biggest platform right now is the 4.0. So the biggest diameter we can now achieve is 4.5. So sometimes if you are treating the left main, you have to be cautious because of the diameter of the stent. So definitely, as it was, the left main was excluded from this trial, definitely by this diameter. So you have to be very cautious in this scenario. But taking into account all other vessels in our coronary tree, so the 4.5 millimeters, it's almost enough in almost all scenarios. So the radial strength is similar to the best in class DES with post-procedure acute gain 1.63 and no acute recoil. It is also very important that after the uncaging of the struts, the radial strength still exists. It is of course a little bit less. It is counted by 30 to 40%. Nevertheless, the vessel is still preserved by the recoil, which could also happen after the 6 months. The tips and tricks regarding these platforms, so overlapping, if we have to use the more than one stent, so the overlapping is needed. So we should follow the PCI best practice, so more or less 1 millimeter overlap and limit overlap, and to maximize the benefits of the bioadapter, of course, because the benefits are connected with the uncaging of the struts. In case of the bifurcation, the side branch access can be opened using a 3.0 millimeter balloon, so while maintaining the integrity of the bioadapter, so most of the side branches could be treated also by this technology because of course of this capacity. And of course we can see the ADAPT-COLOT case report which is available in our resources. In terms of calcified lesions, so of course we have to prepare the lesion because it's the key to ensure optimal bioadapter expansion in the lesion with moderate to severe calcification. Of course, theoretically, you can imagine that the calcium cage the vessel. So when we are using the debulking techniques, we are uncaging the vessel and then again caging by the stent. So probably the effects might be even better in the population of patients with severe calcification, but of course it must be tested in the subsequent trials. And of course, regarding intravascular imaging, so we strongly recommend to use it in every case because it's the modern PCI approach. Nevertheless, it's not specifically required for the bioadapter. And we all know that after the August 2024, we should use imaging in all cases with the complex coronary anatomy. So now I would like to introduce our faculty to show really sophisticated cases, and you can appreciate that in this very complex scenario, this platform behaves as good as the modern stents.
Well, thanks, Michael, for a very kind introduction. I'm Dr. Wong. I'm very delighted to be here on behalf of the cardiology team in the United Christian Hospital of Hong Kong. I'm showing you a case of CHIP-PCI with dynamics bioadapters. So I have no disclosure. My patient was a 57-year-old gentleman, non-smoker, non-drinker, losing work as a teacher, got cardiovascular risk factors, diabetes, dyslipidemia, got chronic coronary artery disease, presented with out-of-hospital cardiac arrest, arrhythmic arrest, defibrillated, resuscitated, lost in 10 minutes, got into cardiogenic shock. Echocardiography showed a very poor LV, 30%. You can see here on the ECG, very critical ischemic pattern, left main equivalent ischemia, basically. So baseline angiogram show distal left main ulcerated plaque here. Obviously, there was the culprit lesion in this case. You can see also downstream very diffuse disease, bifurcation disease in LED diagonal vessel. And the RCA was a CTO, got subtotal-ish CTO lesion, got some retrograde supply, retrograde filling from the left coronary arteries as well. So here's a summary of our problems for our case here, who was a young patient, 57 years old, below 60. He's got a very poor LV function, got a recurrent malignant arrhythmias, very hot lesion, myocardial infarction, cardiogenic shock, and very complex lesions. Basically, you can find everything there, left main, bifurcation lesion, CTO, diffuse disease, limit. So we put in an impeller for hemodynamic support first. Well, I know it might not be the key point of discussion here, but someone might have a different opinion about the order of us doing things, fixing things here. Because, we all knew the LED was the culprit, left main LED was the culprit lesion here, but left main LED got TIMI-3 flow. It doesn't look particularly threatened to close. And on the other side of the coin, the RCA looks relatively protective from the left coronary system because it's got retrograde filling from the LED. So, and the patient got absolutely hemodynamic fine after the insertion of the impeller CP. So we thought it would be safer for us to go for fixing the RCA first during the case. That's why we went on, crack on to do the RCA first, quick wiring, balloon pulver, and imaging guidance. And then we implant 3 long bioadapters, 2.5 by 38 millimeters, 3.5 by 32 millimeters, 3.5 by 18 millimeters, all the way from PDA to the ostium of the RCA. This is the tiny thing we would do, as mentioned by Michael earlier on, about long scaffolding of these bioadapters, because we try to do as minimal overlapping as possible. Mostly, sometimes conjoined as well, mostly maximally 1 to 2 stroke overlapping in order, because we all knew this kind of scaffolds are gonna uncage 6 to 9 months down the line, so we don't want to try to avoid anything that will hinder the uncaging of the coronary vessel in the future. So final angiogram, very good results of the RCA. We then continue on fixing the LED. We do a T-stenting at the LED diagonal bifurcation, professionally stented the left main bifurcation, do a port side port, final port with 4-5 balloon at the left main stent. So again, very nice result of the left main LED diagonal system, as well as you can also see here, there's a stent boost of the bifurcation of LED diagonal. You can see how nicely this stent, this scaffold is conforming the geometry of the bifurcation lesion with proper implantation techniques. Basically, I wasn't an operator doing this case. When I got shown about this picture, I hardly can find the joining point, connection point between the T-stenting of the 2 bioadapters, basically. So it basically worked the same as best-in-class drug-eluting stent acutely for bifurcation lesions. So, sorry. So here's the first 9-month angiogram for the follow-up. Again, very nice result. No stenosis at all. And we did an OCT during the follow-up angio. This showed the return of pulsatility at even the overlapping segment of the RCA stent with the segment overlap between 2 bioadapters. You can see this pulsating movement on longitudinal section of the OCT. There's the stationary OCT with saline injection and take-home messages. The case demonstrated feasibility of bioadapters in treating complex coronary lesions. We got CTO bifurcation, true bifurcation lesions, left main diffuse disease here, and we demonstrated the return of pulsatility even in the overlapping bioadapter segment. So thank you very much.
So thank you, Dr. Wong, for this great presentation. I think that you shown that almost somehow it represents, of course, the INFINITY population. Nevertheless, it was even more complex because it was patient in cardiogenic shock, and you've done, I think, almost all possible techniques in the coronary tree, including CTO, true bifurcation, left main stenting. So my first question will be, do you have any issues with in this acute phase in terms of this platform? It behaves a little somehow different. It was completely the same as the regular stent you are using.
Well, I think in this, because we have been performing this bioadapters in various disease modalities since, I think, in 2022. We have encountered all sorts of anatomy, all sorts of lesion morphologies. Basically, sometimes we need to struggle a bit, particularly in calcified lesion, I think. Well, maybe, but we might just need to do more lesion preparation. Sometimes we all think this scaffold is performing equally well in calcified lesions, but as long as the lesion preparation is adequate. Sometimes there may be a little bit of difficulties in delivering over the side branch. That's what our real-world experience, that the scaffold may get a little bit more difficult for delivery. Of course, some very angulated side branch, but you just don't need to fix all this lesion with bioadapters with with proper lesion preparation, I think it's not that many cases that we encounter difficulty in delivering down the scaffold.
But do you have any situation when you are treating the patient with bioadapter that you have to switch for the nervous stent? No, that didn't happen, for example, for the really complex bifurcation.
Well, it sometimes happens. Okay, as far as I remember, there's I think there's a case that happened to be a very angulated diagonal that might be the deliverability is a bit less comparing to the very ultra thin drug-eluting stent. That's the only case I can think of. But even for drug-eluting stent, they are not at the same. They do not have really a cause effect. Some more deliverable than the others. So we can't expect the scaffold can treat all sorts of patients. But as far as I can remember, the crossover to stent from this scaffold is really very rare.
I think also it was already maybe not was clearly visible because when you are doing the OCT after within the follow-up, so it's clearly visible that all struts are detached after 6. We have 3 cases in which we've done OCT during the acute procedure and then afterwards after 6 months. So it's clearly visible that all struts are detached. So I think it was really important in this case because you touch so many vessels and so many points of the when the pulsality of the coronary tree is important. So I think that even in this such complex case, these issues regarding the behaving of the platform after the 6 months should be pronounced even more because as we see, it was absolutely amazing the results what was shown by Professor Erlinger regarding the proximal LAD. So probably if you would like, if you have to choose, because at that moment you use bioadapters for all lesions. Yes. So and if you have to choose the one segment, maybe not one, but what should be the segment of choice, for example, for the bioadapter? Because you can imagine that, of course, this is a great platform, but of course we all know that the costs are a little bit higher, maybe not a little bit higher than the regular stents. So sometimes we have to choose. When to put some kind of hybrid procedure, yes? When to put the bioadapter and when to put the regular stent. So if you have to choose, you will be upon the results of the trials, or you have your own experience.
Yes, proximal LAD was a perfect site, but somehow the mid-RC is always the more mobile part of a coronary trees. That's why we sometimes think actually. Those segment is a perfect site for bioadapter as well, as long as it can resolve, uncaged 6 months down the line, and they allow the return of the normal curvature, normal mobility of the vessel as such a mobile segment, the mid-RCA. So that would be a potential good site, as in particular when we see loads of stent fracture happening at the mid-RCA when given after a long period of implantation. So maybe bioadapter would be a better option for this kind of patient as well. So the other kind of patient is about the left main lesions, because from your talk that the bioadapter, the maximum expansion limit was 4.5. So we sometimes encounter patients with left main bigger than 4.5. We are more reluctant to put a bioadapters in those cases because we know the post-dilatation limit is going to beyond those of bioadapters. So I think this was the main reason we were doing what you described as a hybrid approach. For bifurcation, yes, at the beginning we are more resistant, but we are the author of the adapt-cool-off thing. So sometimes we have a series of these cases, and surprisingly, we're going to publish it at some point, but maybe by the end of next year. The result of them are actually pretty good. We got 20 patients come back for follow-up study. Majority of them have done a good job. They never come back for recurrent myocardial infarction, recurrent acute event. Just we routinely take them back for follow-up angio for some stage procedure. We found that they're really this kind of scaffold is actually performing a very great job in terms of restenosis. Yes.
Thank you. Maybe there is a question from the audience.
We have some questions here. One interesting, really good question. Is there a relationship between pulsatility and microvascular perfusion? And we don't know, but I would guess so. If you have pulsatility, the endothelium is stimulated for every beat. And that should be good, sending nitric oxide downstream to the microcirculation. So I think that's something that could be the case.
And I think also that there is really a lot of fields which we could test again, yes, and look for, with this new platform, with this new possibility, some things which we hide because of, the capability of the old platforms. Maybe we will open the new doors again and we'll check a lot of things again, because of course the results are so good that probably there will be a room for, another to check it once again. So, if there is no other questions, so I have a great pleasure to introduce Professor Omar Gotekin, who will show even more complicated case. So we'll see how it looks like. Is it possible? We don't know, but.
So I have a case with LED CTO, and before that, I'm working in Memorial Hospital. We do mostly CTOs and complex cases, and we implanted so far like 100 dynamics in those complex scenarios. I think it's important to mention it. And the first case, my case is 46 years old male. He presented with exertional angina. He had diabetes mellitus. Echo is normal. Coronary angiogram performed at another hospital, and he has multivessel coronary artery disease, and he sent to us for PCI because patient has refused to go to surgery. Plan was LADC2 first, and then we plan to implant bioadapter in this patient, and we believe that bioadapter restores adaptive remodeling after 6 months that can compensate for the suboptimal expansion of the typical in the CTO, because CTO we have. Even we open the artery, we believe that artery will grow by time. Like 3 months, 6 months, we see different arteries, total different LADs or RCAs after we open it. So since I know that, I believe that it's important to implant something which expandable, I would say. So that's why I choose Bioadaptor. This is the LAD lesion. It's a subtotal lesion. It's not a difficult CTO, but I mentioned the CTO is a small channel. But diffuse disease LAD, that's I think another issue. I don't think this patient good for surgery for LAD. Anyway, we crossed this lesion easily, but with using microcatheter with help of Pilot 50. And then we changed the wire, of course. And we did some dilatations, 2.530, 2.75, and trio dilatation. This is after dilatations. We have a nice result, actually. But of course, lumen is bigger than that. We know that. And with the IOS, according to IOS, we implanted a 3.028 and 3.523 bioadapter in this proximal LAD, mid to proximal LAD. And then we expanded those to 3.5 by 20, 4.0 by 20. So we expand in this patient 0.5 millimeter more in these two bioadapters. And then we did DCB to distal because we believe that DCB could be good in here as a small vessel, and we believe that it will be grown. And this is after 2 bioadapter and 1 DCB. And then I think the result is not bad. This is the index procedure result. And then we have the patient after 1 year, and we have a nice flow on LAD and shows patent LAD segments. And I'd like to show you pre. This is the pre-PCI. This is the index procedure after post PCI, and this is after 1 year follow-up. So you see that we have now all side branches there, and vessel looks bigger, and also distal vessels became bigger, looks more healthy. So this is very common in CTO scenarios, right, because of underfilling. So also we did IOS. Interestingly, we could able to show. I was always wondering, if there is a difference between implant and follow-up. Yes, we have seen it in our cases, and we have seen it in other many patients. So we have, as you see, here LAD lumen array is maintained at 12 months with 11.4% increase in vessel area. So I don't think it is surprising for us, because I believe that when unlocked after 6 months allows vessel to accommodate no intimal hyperplasia progression to maintain flow of lumen area. So especially in the CTO scenarios, vessel will be larger, and if there is no cage, I think we can see this enlargement after 12 months. Also, this shows us stationary IOs, and each diastole and systole, you can see the difference between lumen area, and each systole and diastole, we have 8.3% enlargement. So again, this is, I think, very similar to RC trials. Anyway, so I think with help of bioadapter, we could have restores adaptive remodeling, restores vessel function like pulsality. I think pulsality is important systole diastole because it gives me that the vessel can be enlarged if it's necessary. Yes, if we give some nitro, for example, after bioadapter, after 6 months or even 1 year, we can see that vessel is larger after that. I think this is important in long-term follow-up. Also, bioadapter can restore vessel geometry, rotation, especially for LAD. I think that's why we have a good result for LAD, because LAD has rotation, each systole and diastole. So that's why we might have a better result in LAD lesion. Also, LAD has a tapered vessel, so proximal and distal size could be different, and that's why I think this gives us, after uncage, bioadapter academic better in LAD lesions. So what I could say that especially patients who are at high risk of stenosis, including CTOs and LAD lesions, small lesions, and also long lesions, I think it's important to use it. And also younger patients with longer lifespan, I think also this technology is important to use in our clinical practice. Thank you very much for your attention.
I just want to ask, you all have quite some experience with bioadapter technology. So for long lesions, if you don't have a long stent and you're going to overlap, what have you seen at the overlap segment where you have 2 layers of stent struts there with the Dynamax? What are your thoughts?
Well, my case showed this evidence of some pulsatility, even at the segment of overlapping bioadapter. I think this property kind of retained even after you're overlapping 2 layers of bioadapters, but we don't have very large data to verify, to validate this thing. So, but it's maybe interested to investigate in the future.
Yeah, so I just want to mention, we have the same question, but you answered it very well, so I think here. And there is a question about TLF and TVF, and TLF is specific for the lesion, TVF covers the whole vessel that you put in the stent. So it's not as specific. And then one more thing to say, many people think that these are fragile small bioadapters, that the links can break or something like that. It's not like that. You should be as brutal as you usually are, and you should not be afraid to post-dilate. You should not be afraid to go to side branches and dilate. And so I don't know if you, with your cases, have the same.
Yeah, I did sometimes 1 millimeter post-dilatation. So after I didn't see anything in the broken strut. So I did actually aggressive.
You use the same pressures and everything as a regular drug-eluting. That's very important.
I have a question for you, Case. You treated the distal end with a DCB. So why not using a bioadapter?
So normally,
because it was 2.5, we saw the very nice results. You presented the results. So just for curiosity.
I mean, I don't like, personally, I don't like to put a distal LAD stent in. Size is too small. I mean, yes, you can trust dynamics in that place too, but I believe that part should be metal-free somehow. Too distal for me to implant a stent. I never implant that LAD. If I have big LAD, big lumen, could be, but otherwise I never put a stent at that level. No.
And I think that you also shown really nice like this, because somehow it could be called the leaving nothing behind technologies, you know, combining DCB with the bioadapter. So I think that's what was also stressed out by Professor Erlinger, that the plaque regression, but it also showed the enlargement of the lumen. So we always, with the current platforms on stents, so it's not possible to have the bigger lumen after the 6 months. So somehow it's also like a DCB effect, less so this positive remodeling after several months after intervention. So I think it's also this is an issue which we cannot expect with any current platform to have the DCB-like effect in terms of the vessel size and vessel lumen. So do you observe it more often, or it was just in this case, this enlargement, the late enlargement of the...
No, actually we do lots of IVOs. We do, for all dynamics, we do 1 year follow-up angiogram. Most of the time we do IVOs. Mm-hmm. So we collect our data ourselves.
And do you observe it it is in every case that you see?
Most of the time we have seen it, yeah.
So I think it's really worth stressing out.
Yeah. And we also saw it in the study, in the randomized study.
So it was a little surprising to see, because there's a metal there stent. We never see it before, exactly. But now it's a pulsatility. I like to see it, that pulsatility effect.
And it's only possible due to the detachment of the struts, yes, because otherwise it's impossible to get this to have this effect.
I believe so. How it could be. Mm.
So, do we have any maybe more questions regarding these cases? So, once again, there are the cases which are not included in the trials because CTO was excluded from, and also the left main was excluded. And so, I think that it somehow really well corresponds with the data from the RCT, that we know that it's moderate complexity population bioadapter works really well, but this real life cases shows us also that even in the highest complexity of the case, the effect is sustained, is continuously the same. So I think that probably nowadays, because we all have to think about the history of the BVS, that everyone was treating everything with the BVS, what was not very smart idea. So, but I think that at that moment when we have this great platform, so I think there will be eagerness to do the same, so very complicated cases. And from my perspective, I think I also have, from my perspective, we are treating almost electively only LAD, and also very complex. Nevertheless, I think that we can do it without any fear about the late outcomes, taking into account your experience in terms of the.
I think this device is very good for complex scenarios, I believe. The only thing is crossing for profile. It's good, but not the best. We should know it. You may need to use guide extension or anchoring balloon in very complex scenarios. But otherwise, I think even if we do in complex patients, we will have more benefit. And to me, I believe that it's more forgiven if we treat calcified lesion, because calcified lesion, if you didn't prepare well lesion, if you do have under expansion, for example, accidentally, I would say. No one wanted, but sometimes it could happen. We believe that we break the calcium, but sometimes not. In that case, we will have under expansion, right? So in circular, in certain level of the stent. In that case, I think if we have dynamics, the link will be released, and then the expansion of the stent could be possible after 6 months. But otherwise, it's almost impossible to expand under expanded stent. What do you think? That's theoretically. I don't have any patients like that, but in theory, I could have an advantage of this link release.
I think so, and especially like CTOs that grow after you open that vessel. We've all seen that in real life. The only thing I want to circle back to is the trials maybe did exclude left mains and CTOs, but complex lesions were still included to a certain percent. I mean, there were calcified lesions, tortuous lesions, calcified lesions, and again, the results were actually very impressive, even in that subset of patients. I think maybe the one thing we've learned over time, from the time of the bioabsorbable technology, which is not the same, it's completely different technology, is really imaging and pre-treatment. So lesion preparation, and now it's something that we all do even for your standard drug-eluting stents. It just helps you not only deliver the stent, but helps you expand it to what you really want it to reach.
Yeah, I completely agree. I think it's very important also for the audience that it's not a scaffold. It's a completely new and different design. Of course, you need lesion preparation. You need that for every lesion, and especially for calcified lesion. I think that's also pretty sure. But I think we see the results, what we see, because it's a completely new design, and that has nothing to do with scaffolds.
Exactly, I think it's very important not to connect the detachment of the stents with the BVS, because it's completely different.
I think to me only issue is the price. Otherwise, all stents has to have this feature to me. All stents has to have, you know, this thing. All stent has to have this kind of feature. But the only thing is price here. Otherwise,
I think that's
very good.
This is the only
features.
bad news about this device. Everything
I hope
is really great. We have a really great question. I don't have my personal experience about using IVL after stent implantation. So, do you have such situation? Does it influence, for example, the struts? Do you use IVL after stent?
Do you mean for dynamics?
Bioadapter.
No, I don't have any experience.
So that's a good job for the company to test IVL on the adapters. I see the engineers, they're laughing already.
So probably we have to be prepared for the next symposium with this, with answer of this question. So I think now it's Professor Erling.
I think we had a really great discussion. And first we had a lot of bullet points on this slide. We could read the same things that we said before, but I think these two images just tells you everything you need to know. Now we have long-term data up to 3 years where the bioadapter has flattened the event curve compared to one of the best drug-eluting stents we have on the market. And it's significant for superiority, and this is exactly what we have been looking for many, many years. And the right-hand image from one of the cases shows this pulsatility. And I think it's where you actually have the overlapping bioadapters. You see a strong pulsatility. And I think this is a key. This is the explanation for the Kaplan-Meier curve and the good events. So physiology is a good thing. It's there for some reason, and now we can restore it. Thank you.